morning. Welcome to week 9. We have a bunch of information to go over today. So the plan is we will do 2 chapters. We'll do a Kahoot. We'll do 2 more chapters. We'll do another Kahoot, and then you'll have your quiz 5. So I hope everyone is ready. Unfortunately, there is information from today's class that's on the quiz 5. So I strongly encourage you to participate, really pay attention to the Kahoots. I think you should do fine on the quizzes if you're here and being engaged in class. And then someone said they're going to go to the reviews. I strongly encourage you. There's one today, and then there's one on Saturday for your exam 3. Your homework grades are turned on right now, and I'll turn them off after your exam 3. So does anyone have any questions about anything before we get started?
You don't remember Ricardo?
You said that there will be, I'm sorry, my audio was cutting out. You said that there will be questions from today from the Kahoot on the quiz?
Yes.
Okay.
And then Chris Jones, as soon as you get a chance, if you can go ahead and flip your camera on. Okay, I'm going to start sharing my screen with you guys. Thank you, Chris. Okay, so we're going to start with the genital urinary conditions. This is primarily going to be more about, urinary tract infections, etc. Whenever we're talking about pediatrics, so we do need to remember, kids can be abused, and one of the systems where you might first see abuse is in the genital urinary system. So if you're I think we've talked about before, as a nurse, you're a mandatory reporter. So there's some key things that you need to be paying attention to that could be an indication of sexual abuse that should prompt you to follow up. So, excessive masturbation, daytime wetting their pants, having bad nightmares, also bedwetting at night, just complaining of general pain or irritation in the genital area, or even frequent urinary tract infections. So you never want to falsely accuse or suspect someone of child abuse, but you just need to be aware that the genital urinary system is one of the symptoms or one of the systems where if a child is being abused, you might see evidence of that when you're examining them or evaluating them for a specific complaint. So the genital urinary system is the genitals, it's the urethra, it's the bladder, it's the ureters that connect the bladder to the kidneys, and it's the kidneys. So there's a bunch of different tests that we can do to evaluate the genital urinary system. I would kind of be familiar, generally speaking, with what they are. But the main thing is to kind of recognize it's the whole apparatus from the genitals up to the kidneys. And sometimes you need to evaluate things within that entire system. So there are some key words that are commonly used to describe urinary dysfunction. So I'd love it if you guys could tell me what these words mean. So can someone tell me what dysuria means?
Painful urination.
Okay. How about frequency?
Often.
Yeah, you have to go a lot. Yeah. And what's the difference between frequency and urgency?
Urgency is right now, and the other one is a lot.
Yeah. So when you have the
Frequency.
feeling of urgency, you feel like you can't, you feel like you're going to pee your pants, like you're fully potty trained, you're an adult, and you feel like if you don't go right now, you're going to pee your pants. And how about nocturia?
At night.
Night, when you pee at night. And then enuresis. Yeah, that's just a fancy word for wetting your pants. So nocturnal enuresis is bedwetting. Polyuria.
A lot.
A lot. So a lot of urine output. And oliguria.
None.
No, or little. So it's the opposite of poly. So like when you're going into renal failure and you're not really producing much urine, then you have oliguria. So there's a couple different ways that you can have abnormalities in the urinary tract. So this is first couple here are going to be very specific to boys. So phimosis is when the foreskin is tight. So you can't pull it back and put it back over the shaft of the penis. So this can lead to a medical emergency. It can cut off circulation to the head of the penis. So you do need to get medical attention if this happens. And it can just be that that the foreskin is too narrow, or sometimes when parents are cleaning or something, they push it back and then they don't pull it down right away and there's some swelling and then they can't get it over the tip of the penis. So just be aware that, sometimes we laugh or joke about genitalia. This is something that's really an emergency. Like they can have damage to their penis if they don't repair the phimosis. So you do need to, if you're ever counseling parents about this, if you don't want them to forcefully pull it down, you need to bring them in to get medical attention. And then there's two, epispadias and hypospadias. These are both conditions specifically related to the position of the urethra. So the urethra is the tube that the urine comes out of. So in epispadias, the urethra is on the top part of the penis, and then hypospadias is on the bottom. So there'll be a picture in just a second. In really mild cases, they just leave it alone, but most of the time they surgically repair it. So they usually do the surgery in the first 18 months of life, not right as a newborn, but before they're, trying to potty train or anything like that. And they recommend that parents not circumcise their sons if they have an epispadias or hypospadias, because they use the foreskin for the surgical repair. So this is just the picture. This is the epispadias, where the urethra is on the top of the penis, and the hypopadias is down here at the bottom. So you would normally expect it to be in the middle. So exstrophy of the bladder, this is something can happen to both boys and girls. So the lower portion of the abdominal wall is missing. So the bladder is exposed. This is something that is very rare, but you definitely see it, if the mom's getting prenatal care and getting prenatal ultrasounds, you should see it on a prenatal ultrasound. So, but the bladder is exposed and the urine just leaks continually from the bladder and can damage the surrounding skin. So they have to go to surgery soon after they're born. You don't diaper them, you put diapers under them, and then you usually cover it with like a plastic or something so that you kind of minimize the risk of infection. And you never put them on their back, right? Because that's just an exposed area. So they're always going to be laying on their back. Not going to put them on their stomach. I'm sorry. You're never going to put pressure on that exposed area. And then they're not going to eat or anything before they go to the surgery. They're going to be born. You're going to stabilize them after birth, and then they're going to go and have their surgery as a newborn. So obstructive uropathy. So this just is kind of, as the title of the condition suggests, there's an obstruction somewhere in the urinary system, somewhere between where the urine exits the body up to the kidneys. So it can be like a stricture, a narrowing, scar tissue, like a kidney stone or a calculi. So depending on what's going on, they might need to have surgery. And so, just to remember that always think about the age of your child that might need to have surgery. So, surgery when you're a toddler, that's really hard because you're starting to potty train and you really want to gain your independence, and you take them away and put them in the hospital. School-age children really suffer because they're being different from their peers. And then the adolescent could be worried about self-esteem and how this is going to affect their sexuality. So if they ever have to have surgery for whatever reason, and you're thinking about how it's going to be their nurse, to just think about how their developmental age is going to influence how they feel about the surgery. So one of the most common conditions you're going to see in the genital urinary system is going to be an acute urinary tract infection. So why is it that your girls are more likely to get a urinary tract infection than a boy? What's different about the girls' anatomy?
The way they clean.
Their
Could be the way-
Close
urethra,
to the anus.
their urethra
Yeah.
is shorter.
Very good. So everyone's right? So the urethra is shorter. So just think, the urethra on a boy, it comes all the way out the end of the penis, and the girls, it's right there. It's right near their anus. So there's just more bacteria near the urethra of the girl. So this is why it's really important to talk about how they wipe, how they clean themselves after they go to the bathroom, wearing cotton underwear, not taking a lot of bubble baths. You don't want to introduce extra fluid into their vagina. And retention of urine. So retention of urine is just like kids that don't want to go to the bathroom, that they hold their urine in their bladder. So when you do that, when there's what's called stasis, when you're not having fluid move through, then it's more likely to grow bacteria. And vaginitis is just inflammation of the vagina. So it's most often caused by E. coli. So that's going to be one of the main bacteria in your poop. And this normal urine is acidic. and alkaline urine favors pathogens. So how do you keep your urine acidic? What can you drink to help your urine stay acidic?
Is that orange juice?
Orange juice is one, and there's another one that sometimes people take. It's another
Cranberry
juice.
juice.
Cranberry juice. Yep.
Cranberry.
Yep. So, you know, obviously certain kids are gonna be able to tell you different things depending on their age. So the signs and symptoms of a urinary tract infection is really gonna depend on their age. But kids, like little kids, sometimes it's just fever, sometimes it's fever and vomiting. When they're older, they're probably gonna be complaining more about pain with urination and urgency and frequency, etc. So kids that are under a year, they're more than likely going to need IV antibiotics. Older kids usually can be treated at home. And then, you know, you do want to like keep their urine dilute and moving through. So sometimes when they're, you know, recovering from a urinary tract infection, you want to encourage fluid intake so they pee frequently. And we talked about this earlier in the class. What's the best way to get a sterile urine sample or a good urine sample from a baby that's not potty trained yet? If you suspect a urinary tract infection in a 6-month-old, how are you going to get their urine to send it to the lab?
Through their diaper?
The bag and over the general. And you just
So
wait till
they
go.
have bags. They have bags where you clean it and you like put a sterile bag over there.
Yeah.
So, but in like when you're taking the NCLEX or HESI, you always think about the ideal situation. So the ideal situation is that you do a calf specimen, that you do a what's called a sterile straight calf. So parents don't like it. You
In and
gotta
out.
in and out. You just go in, you get the urine, and you're done. But you have to be sterile gloves, clean the area, etc. But this is a commonly sort of tested question. You know, it's really important that you get the right antibiotics. You don't want to be creating bacterial resistance. You know, if you put somebody on an antibiotic for the urinary tract infection and it doesn't really treat that bacteria, then they can develop resistance and it'll be harder to treat the next urinary tract infection. So really, if they're not able to follow directions and clean themselves and pee in a cup, then the best way to get the urine sample is to do a straight calf. And I will say that I know that those bags exist and I've used them myself, but if you're taking a HESI or an NCLEX, the best way to get a urine sample from a kid that's not potty trained yet is going to be the straight calf.
Just lay down right there. You're stressing me out. Sorry.
That's okay. You know, there's certain things that you want to make sure that you're teaching parents about: wiping from front to back, avoiding bubble bath, have them pee as soon as they get out of the bath. That kind of flushes out anything that could come in, the cotton underwear, loose fitting pants, the adequate fluid intake so they don't have stasis of urine. So nephrotic syndrome is an umbrella term for a series of conditions that affect the kidney, the glomerular area of the kidney. So the primary thing that you need to associate, so when you see nephrotic syndrome, you need to think massive protein loss in the urine. So this is going to be very, very high levels of protein in the urine. And it's frequently like an autoimmune problem, and it's like a lifelong problem. They have remissions and exacerbations, and they tend to take typical autoimmune medications like prednisone to treat it. But the key concept with nephrotic syndrome is massive protein loss in the urine. So if you have protein in your blood and it goes through your kidneys and you lose a lot of protein in your urine, what happens to the quantity of protein in your blood? Is it high, low, or normal?
High.
So you're losing it in your urine. So it's
So
in your
it's
blood,
low.
it gets to your kidneys, and you lose it in your urine. So then it's low.
So it's low, yeah.
So what happens, what happens when you have low protein in your body? What sort of physical exam findings do you have?
You don't heal as well?
Muscle weakness.
Yeah, you don't heal as well. You're not going to feel well. You're going to have poor wound healing. Yeah, those are both true. Are you edematous or are you not edematous?
Mm.
So
I wouldn't think you would be swollen.
So you actually are swollen because the protein, it holds fluid. So if you imagine you have like your blood vessel and they have protein in it, the protein is an attraction for fluid. So it keeps fluid in the blood vessel. So when you have nephrotic syndrome, the primary physical characteristic, all the things you said, poor wound healing, not feeling well, those are both true. But when you look at them, one of the things that you're going to see is generalized edema because they're losing so much protein in their urine. They don't have it in their bloodstream, and that protein in your bloodstream, it keeps your fluid in the right place. So then it doesn't leak out and cause edema. But, you know, pale irritabilis, you guys got that. Like they're just not going to feel good. They're not going to have normal immune function. Their blood pressure is usually normal. In more severe cases, it can be off, but the main thing is this kind of edematous. And they're prone to infection because someone else said, you know, when you don't have your proteins, you don't have the same immune system. And also it's an autoimmune condition. So they take a lot of prednisone, which then tampers their immune system. So the primary treatment is going to be something like prednisone. And they will sometimes give them diuretics. A lot of times, maybe they'll give them some protein followed by some diuretics to kind of help move their fluid off. You do, you want to encourage them to not eat a lot of salt, just like someone like an adult that's in heart failure and they have edema. They have to have a low salt diet. And then sometimes they actually do fluid restriction also, just because their capillaries are so leaky and they're so edematous. So in terms of, you know, helping parents and the kids manage, it's a lifelong illness. So it's not something they're going to outgrow. It does have remissions and exacerbations, but they need to be prepared to like taking medication for the rest of their life. And then to think about their vaccination. So do we give people vaccines when they're immune compromised?
No.
No.
I
So you
always
gotta be
think
thinking.
no, but they say yes. Yeah.
So it's certainly not like because some of the vaccines are the live attenuated viruses, like the flu vaccine or the varicella vaccine. Some of them are a little bit more dangerous than others. So for sure, you want to have a conversation with the provider. But, you know, again, in like ideal NCLEX HESI world, if they're immune compromised, you want to hold the vaccines until you get a firm grasp on what's going on with their immune system. So this will be something that you'll see again, you know, especially if they're like HIV patients, you're gonna make sure you have a good conversation about their immune system before you vaccinate them. So this is the same thing with nephrotic syndrome, especially if they're currently taking prednisone. Maybe they're going to get their vaccines, but you're going to wait until they're in like a remission stage of the nephrotic syndrome and they're not taking the prednisone. So when you're taking care of them, you're going to do daily weights, a lot of, you know, infection control, good hand washing, et cetera, because of their impaired immune system. So acute glomerular nephritis, this is a kidney problem that's after you have a strep throat infection. So last week or the week before, we talked about rheumatic fever, which is like a problem with your heart valves more than likely after a strep throat infection. So this is like another problem that you can have after a strep throat infection, where this is where you have an allergic reaction to the bacteria that causes strep throat, and those antibodies attack your kidney. So acute glomerular nephritis is something that happens after a strep throat infection. It usually affects both kidneys, and there's a pretty wide range. Sometimes they just don't feel good and they kind of have a drop in their urine output for a few days, and sometimes they go into kidney failure and they need dialysis. So there's a wide range of the spectrum of how bad they're affected. So Wilms tumor is it's a kidney tumor that's common or more common in childhood than in adulthood. So it's usually young kids before the age of 3. Sometimes they don't have any symptoms, and a lot of times it's the parents, they feel a mass and they do an evaluation and they find the tumor. So, you know, when something's happening with the kidney, it can cause problems with fluid retention. They can end up with hypertension. So this is something that is commonly tested, this point here, that once they're diagnosed, that you don't do any abdominal palpitation until they've had the tumor. It's usually the tumor and the kidney. They take the whole kidney out until that's been removed. So they usually have a sign above their bed that says no abdominal palpation. You can listen for bowel sounds. You can kind of assess gently, but you don't want to be palpating anywhere near that tumor and this, sign above the bed, so that anyone walking into the room knows that you're not going to be really touching that belly. So they almost always, it's usually just one kidney. They usually take the kidney and the tumor out. And then after they do the surgery, it's the chemo and radiation. So they're going to have, an abdominal wound and your kind of routine postoperative care following an abdominal surgery. So hydrocele, this just means a lot of fluid around the testicle sac. So sometimes, I don't know if anyone's seen a baby boy, sometimes that area just it looks really swollen right when they're born. It usually just goes away on its own. If it's not, the fluid around the testicle doesn't go away by a year, then they can surgically remove it. But sometimes parents are worried because it looks kind of strange. But usually it's just this swelling that gets reabsorbed and it gets better on its own. So I have a really hard time pronouncing this word, cryptocridism. This is just the testes fail to descend into the scrotum. So they develop inside your body and then they should fall into the scrotal sac. And if that doesn't happen, then sometimes they need to have surgery to pull them down. So it can be one or both. It's usually more common for it to just be one testes that doesn't descend. It can impact fertility. So the inside of your abdomen is warmer than the outside of your body. So if your testes are inside your abdomen, then you don't have the same ability to produce sperm. It can be accompanied by an inguinal hernia. So even though it affects sperm production, if they're not brought back down, they still produce their normal sex hormones, so puberty, etc., is not affected. So sometimes they give HCG and that'll stimulate the testes to descend, or they might need to have surgery to pull them down. And children that have this condition are at increased risk of testicular tumors as they reach adulthood. So you want to, do the things that you would consider for doing any sort of genital surgery. Make sure that you're having an open mind, not making them feel embarrassed. And you need to teach them, all boys, how to do testicular exams. And then make sure that they understand this is just their testicles. It doesn't have anything to do with their penis or their ability to go through puberty or anything like that. And I said earlier, always want to be thinking about the age of your patient in terms of how they're going to respond to needing surgery or being in the hospital. Between the ages of 3 and 6, they're really curious about their own body, and then maybe they start to masturbate. So being in the hospital and being refrained and having people talk about their genitalia can be really hard on them. So just always be thinking about what age they are if they're needing to have surgery. Does anyone have any questions about that information? Okay. I'm going to get out of here. We're going to go ahead and pull up the next PowerPoint here. So we're going to do skin next. Okay. So, you know, the skin, the hair, fingernails, toenails is all part of the integumentary system. What do you think some differences are between kids and adults? How do you think kids' skin absorbs more medicine if you put it on than adult, or less? How do kids differ from adults in terms of their integumentary system?
Is it less because they're so small?
So it's actually more. It
Mm.
absorbs more. So they're higher risk for medication toxicity if you're putting something on their skin. So just always think about kids. They're more likely to have complications from getting too much of a medication. So you need to be careful about putting creams and stuff on their skin because they absorb it really well. And they also have a higher body surface area to their mass. So there's kind of, you know, relation to their body. They have more skin. So when you're documenting, I think in nursing, just always remember what you document is so important. So you're thinking about the color of the skin, any rashes or lesions, and always remembering things like, you know, itching can be something systemic. Like they're not necessarily itching because they were bit by a bug. It'd be something going on with their liver. There's something going on that you're going to see in their skin that's, you know, related to a bigger problem. And then problems with your hair, not growing hair well, or having really brittle, thin hair, all of this can be like a nutritional problem. So just paying attention to the skin. It's not, you know, the skin and the hair can be an indication of something else that can be going on with the body. And then also if they have just like a rash or whatever, that you know the terms to use to describe what you're seeing on their skin. So these are, you know, if they have any sort of a lesion or a cut, these are all the different things that you're going to be talking about, like the size, the color, configuration. Is it round? Is it elongated? Is it itch or painful? Where is it on the body? And then what does the skin look like around that lesion? So, you know, once there's a break in the skin, then they can get a secondary infection. They can have bacteria enters the bloodstream. You want to kind of keep areas clean and dry and covered for the most part, and try to prevent kids from scratching, etc. And then this one here, this goes over the different types of terms that we use to describe skin conditions. So like a macule is a flat rash, and a vesicle is an elevated fluid filled, and a pustule is an elevated pus filled. And a papule is elevated, like a pimple. A scab is like something like a pimple that scabbed over, and a wheal, this is something that you see like an infection. It's kind of a hard, small bump. So I would recognize all of these, and it's good when you're documenting, like if someone comes in with a rash, you know, if it's a pustule, you're more worried about infection than a macule, right? Because a pustule is pus. So just to be able to recognize these different terms, and if you see a rash on somebody, to be able to use the correct term to describe the rash. So a sty, sometimes you'll see that kind of is usually on their lower eyelid. It's like a ingrown eyelash. You see it commonly. You can kind of put warm compresses on, and sometimes they'll go away, and sometimes they need antibiotics. So just to be aware that this is not uncommon in pediatrics. There's a couple of different spots on kids that you need to be aware of. So a port wine nevus is present at birth. And it's caused by dilated dermal capillaries. And they're kind of like as the name suggests, like a purplish color. And they can be really bothersome. Parents can be concerned about it. Usually they're not a problem. And they don't need to do anything, but it's not a very nice thing to look at. And parents can be concerned that their kid has it. And it's, you know, from the difference between like a port wine nevus is that the port wine nevus is going to be present at birth, and the strawberry nevus is not. It comes in a couple weeks after birth. But it's the same thing where it's dilated capillaries. And this usually disappears without treatment, and it's flat, and it can be a couple of different colors. So there are like, you can do like laser therapy. There are certain things that you can do to help these go away. Sometimes it's not necessary. The strawberry nevus, sometimes this goes away on its own. So the main thing for parents is you need to let them know that it's not, generally speaking, it's not dangerous. If it's near their mouth or their nose, you can be more concerned about airway problems, but almost always it's something that's benign, it's harmless, and they don't really need to worry about it. And then there's two other skin manifestations that you might see in children, and these two you both need to be a little bit more worried about. So the cafe au lait macules, usually they're on their back, and they're these light brown oval patches, and they can be associated with neurofibromatosis and tuberous sclerosis. So both of these are conditions that can cause tumors to happen throughout the body. So if you see these cafe au lait or these hypopigmented macules, then you need to be getting them in to see like a specialist and having more an evaluation done, because they can be associated with widespread tumor formation throughout the body. So you've probably talked about the butterfly rash before, and it says it here, but what disease do you sometimes, or do you associate with the butterfly rash, that rash that goes across the bridge of the nose and the cheeks?
Lupus.
Lupus. So kids can get lupus too. Sometimes you'll see lupus in kids. So if you see that very characteristic butterfly rash, you need to be associated it maybe with SLE. And the scaling skin eruption. So it's kind of like dry, flaky skin, usually on the chin, cheeks, or in the diaper area. It can be associated with nutritional deficiencies. So if you see it, you need to be doing a more thorough diet evaluation. And then sometimes kids are just born with a birthmark. And then the hemangiomas, like I said, if there's something on the chin or the mouth, sometimes you need to be more worried about those types of birthmarks, because they can be associated with airway problems. But there can also be problems with the lumbar region if you see a birthmark on the spine. But these are really the only two reasons that you would be worried about a birthmark. Usually they're benign and you don't need to do anything. So obviously you can have infections on your skin. So miliaria is just that prickly heat. They call it like a heat rash in babies. So you're likely going to see it kind of in the areas, in their skin folds, et cetera, where they're hotter. So you can see it like in their diaper area, and you really just need to kind of keep the area clean and dry. It's not that big of a deal. This intertigo is the chafing in between skin folds. So this is another one that, the main thing is to kind of keep that area clean and dry. They can get like a yeast infection if you're not keeping the area clean and dry. So this is something to just kind of help educate parents about. And this cradle cap, has anyone had a baby with cradle cap before or dealt with cradle cap? Yeah, Teresa, what was it like?
It's very hard to get out, but like her skin is very dry and it looks like buildup.
Yeah. And so do you guys have a comb, or what did you do when she had it?
So I used a comb. I have it looks like a little circle, and
Okay.
it's like a scrub for her head.
Yeah.
I use that for the bath, and I use like Aquaphor if I need it.
Okay. Yeah. So sometimes they recommend maybe putting some oil on their head at night, and then having them go to bed, and then in the morning when you bathe them and wash their hair, sometimes that oil will kind of help loosen it up. It's not pretty, but it's also not dangerous, and it doesn't bother them. It doesn't itch or anything like that. It's just kind of like this, like you said, like it looks like buildup on their head. And it's kind of like a yellow scaly kind of a
It
color.
looks like dandruff too. My daughter had that.
Yeah. Parents don't like it. Sometimes they get really nervous about it, but it really is not something that's, it doesn't set them up for an infection. They're not bothered by it. They don't know what it looks like. So, I mean, it's important to just kind of help parents understand that. And it usually gets better. For those of you that you said your daughter had, but by the time she was like 6-7 months old, was it just gone?
Yeah, it was gone. I would get this brush from Amazon. It was like this prickly brush.
Yeah.
That I was recommended. And then I just did it with her shampoo, and then just did circular motions.
And you
and
kind of
come off. Yeah.
So, but if you're working in pediatrics, it is something that you're going to be aware of, because a lot of first-time moms don't know what it is, and they can be worried about it. So sounds like both of you, and neither one of you, your kids they're not bothered by it, right? They don't scratch their head or anything like that.
No.
No. Mm-mm.
And all you parents out there, I'm sure you're familiar with diaper rash, so diaper dermatitis. So obviously one of the things, doing frequent diaper changes can kind of help minimize this risk. And also just kind of, if you can, let their butt just kind of air out a little bit. So you take the diaper off and you clean them and just let them be exposed to a little bit of air. If it's like a beefy red or kind of spreading out a lot, it could be a candida infection, in which case they would need like an antifungal cream. So this is one that you'll need to be doing a lot of education, anticipatory guidance when you're working in pediatrics. Obviously, if they have diarrhea or something like that, that can make the diaper rash worse. So acne vulgaris, this is something you're going to see more in adolescence. It's just that, the pimple with the whitehead, or you can also get blackheads. So, you can kind of minimize it with good diet, getting enough sleep, routine skin cleaning. Sometimes they need medications. This is something that, you might see in an outpatient center where they're having, sometimes they take antibiotics, et cetera, for their acne. So this herpes simplex type 1, this causes those fever blisters that kids get on their lips. So once they rupture, it can take up to 10 days to heal. So they can have that exposed blister for a while. And it is, transmittable. So you don't want them sharing water cups or something like that. Sometimes kids that have them, they'll get them under stress, or sometimes girls will have outbreaks when they're going to get their period. So just to know that it can lay dormant and then there can be an eruption of the fever blister, and it can be treated with antiviral medications. So eczema, what is a non-skin condition that you associate with eczema? If you have eczema, what are you likely to have also?
Is it
Asthma.
Asthma, very good. So atopic dermatitis, it's usually kind of like an inflammatory allergic reaction problem. And a lot of people that have eczema also have asthma. So always try to be thinking about that. If you're seeing eczema in a kid, that you're also paying attention to their allergies in general and their breathing, and kind of doing an evaluation of whether or not they have asthma. So, and you once they have an outbreak of eczema, then they're at risk for getting a secondary infection. So, helping parents be good about, keeping fingernails short and not having the kids really scratch or touch the area. You do want to make sure they're not having contact with things that could be infectious, including like cold sores, because they can develop an infection in that area. Sometimes they'll have a flare up after immunizations. You need to be careful with steroid creams for this kid, because they can have absorption in the bloodstream, and a lot of steroid use in kids can be harmful. So a lot of times they try to do like non-pharmacological things like oatmeal baths or a mixture of cornstarch and baking soda to kind of help ease the itching, because it is really annoying. And this just is pointing out that, the last thing that you want to do, I mean, if you have to do it, you can use the cortisone creams, but they don't resolve the underlying cause. They might stop the itching, and then you have to just be worried about the amount of steroids they're being exposed to. You do want to, usually you want to give them a bath, pat them dry, and then put the creams on after their bath. You want to make sure that you're wiping the cream off in between applications. And sometimes you might have to a little bit restrain the kids, like elbow restraints or something like that, so they can't itch their skin that much. So the staphylococcal, so this bacteria is present on all of your skin. So if it becomes an infection, it can become a problem. So think about, newborns, umbilicus and circumcision. This is two areas where you might see a staphylococcal infection. So you need to be on the lookout. If they have small pustules in the newborn period, that's something that, if you were to ask what you should do, you should get medical attention, because the staphylococcal infection can start with just these small pustules. Then they can get really sick, like can enter their bloodstream, and they can get sepsis. So if you see these small pustules, you need to make sure that you're telling the doctor. And then always remember that MRSA is just a version of the, it's a methicillin resistant Staph aureus. So this is just going to be like in communities that have MRSA, if they have a staphylococcal infection, it could actually be MRSA. So then they're going to need a different selection of antibiotics. So scalded skin syndrome is going to be specifically caused by Staph aureus. And this one is very, very specifically like a widespread, usually kind of a red color, and their skin feels like sandpaper. So it has a very, very specific sort of rash. And they can become quite sick. So they are going to need antibiotics because it's a bacterial infection. But the vesicles don't usually cause any scarring or anything like that, but just to kind of be aware when they have that sandpapery rash, it could be this bacterial infection, and they really do need to be on antibiotics. So impetigo, has anyone been around a kid that had impetigo or know what impetigo looks like?
It almost looks like
look
a
like
cigarette
chicken
burn.
pox.
Yeah. I bet all of you parents that have kids in daycare have experienced this. Like, oh, someone said it almost looks like a cigarette burn. It's kind of like a yellowish, crusty color, the little vesicles that open up. And it's very, very contagious. So it spreads easily from kid to kid, and they do need to be on treatment. It's kind of like this, they call it honey colored crusties. And they usually recommend that you kind of you gently wipe off the crusties, and then sometimes they're treated with oral antibiotics, and sometimes they just put an antibiotic cream over the area. But it is very contagious, and you do need to treat it because it'll spread quickly between kids. So you can have fungal infections. So this would be like jock itch, what's the one on your foot? Athlete's foot. You can also have it on your head. So if it's a fungal infection, that you need the appropriate sort of fungal treatment, it's not going to respond to antibiotics, and they can be really itchy. So pediculosis is just the medical term for lice. So you can have it, in your head, your pubic area, or you can also actually have it on your body. The most common area is going to be on your head. This is something that's also very contagious. What sorts of things do you recommend parents do for lice? You guys ever experienced lice in your kids before?
Clean thoroughly. Extreme hot temperatures.
Yeah. And have you ever had to comb to try to get the nits out?
Yeah, you have to comb the nits out.
Yeah, the
Shampoo.
eggs. The egg sacs are really sticky, and they stick to the hair shaft. So you have to get all of those egg sacs out, or they'll just keep getting infected. So scabies is technically a parasite, and you'll see like they burrow under the skin. So a lot of times you'll see it in between like their fingers, and you'll see like little lines that go up between their fingers, and that's actually the scabies mite that's burrowing under the skin and laying their eggs. It's very, very itchy. It's also very contagious. There's a specific medication that they need to take, and it's one of those things that it's really hard to get rid of. They have to wash everything in hot water. All the family members need to be treated. Just to, just to be aware of it. It doesn't happen that often, but when it does happen, it can be really psychologically hard for the family because it's extremely itchy and it's pretty hard to get rid of. So when we're talking about skin, probably one of the more dangerous things is going to be burns. So it's a leading cause of death between the ages of 1 and 4, accidental death. So you can also be a sign of child abuse and neglect. You just need to be watching kids around things that are hot. So we always think about it being thermal, but it can be a chemical, electrical, there can be radiation. There's different sort of substances that can burn people. So something to always think about. So if you have a burn on the face, what are you worried about? What's your highest nursing priority? The nose or mouth?
The ABC, the airways.
Yeah, airway. Having somebody come in, you got to be thinking about doing an airway assessment. And y'all have heard of the rule of 9s?
Yes.
So can someone just summarize the rule of 9s for me?
9% per body
18.
position.
Okay. So this is how you estimate the percentage of body surface area that's burned. So it's a little bit tricky because I would say Over 10 kilos, the rule of 9 works really well, but in the younger kids, like they have a bigger head, they're kind of short and squatty. So the rule of 9 doesn't work that well for really small kids. So sometimes you might want to, if you really have to estimate their body surface area that's been burned, sometimes in the younger kids, it's maybe better to use a table, but I would recognize the rule of 9s. And then you're going to be thinking about, you know, what percentage of their body is burned in terms of grading the burn. Like a moderate or a severe burn is going to be depending on what percentage of their body is burned. So still remember the rule of 9s, but I would just file in your brain when they're really small. It's hard to use that exactly just because their body proportions aren't the same as an adult's. And then when they do have a burn, you know, what sorts of problems do they have? Someone said airway, if it's near their nose and mouth. What other problems, you know, can burns cause?
Electrolyte
Fluid
imbalances,
Mm-hmm.
fluids,
Very
Heat
good.
loss.
Yes, very good. And they're also set up
infection.
for infection, right? Because the skin is like your protective barrier that helps you from getting infected. So they do need lots of protein and calories. Like a lot of their tissue has been damaged and they need extra protein and calories to help recover. And you need to be thinking about fluid and electrolyte shifts also. So children, so they have less muscle and fat than adults. So they're more likely to not have all the protein their body needs to heal. So they're even more at risk for nutritional deficiencies following a burn. And their skin is also more elastic. So they're more likely to have a larger scar formation. So kids are kind of a setup for even more problems if they have a burn. And always thinking about kids if they're in the hospital and they're not mobilized, you know, this can really affect their psychosocial development, and thinking about things that you can do to help a kid stay developmentally on track if they're in the hospital. You should recognize, you know, moderate and major. So a moderate is going to be partial thickness that's 50 to 30%, or full thickness that's 10%. And major is partial thickness that's more than 30, or full thickness that's more than 10. And what do you do? Like, so they come in, you're the center that receives them, and they're going to go to a burn center. If they like burned their hand, do you put petroleum jelly on it? What do you do if you see like a burned hand that has a blister?
You definitely don't put petroleum jelly on it because isn't that
Okay.
flammable?
Yeah, it's flammable, and it also traps the heat in, right? Because you don't want the area to continue to be hot. And so those greasy sort of substances kind of keep the heat trapped in. Do you rupture? Do you break the blisters?
No, right?
No, you don't.
No.
Because you want the skin to heal underneath. So when you break the blister, that's just an additional setup for infection. So you're not going to break the blisters. You might put it in some cool water. You don't want to do ice because that would be too cold. But just, you know, if a hand's been burned, some cool water to kind of help get the heat away is a good thing to do. And then you're not going to be putting any sort of jelly, oily stuff on top of the burn.
Would you put a sterile dressing over it too?
You could put a sterile dressing over it, yeah, and make sure the kid's not like touching it, but a sterile dressing that can breathe, right? You still want it to get air, but something like a gauze or something like that, and they can't scratch it or do anything, yeah. So electrical burns, you know, this can cause problems with heart rhythm, etc. So you need to be paying attention to where it entered and exit the body. These are not going to be very common, but you know, they could like grab a live wire or something like that. And also to think about, you know, muscle damage can occur in the rare instance that they have an electrical burn. So you guys, I think you guys got this. So, you know, someone said cover the injury, evaluate it, not putting anything really over it. You're going to get them to the closest hospital. A lot of times they go to like a specific burn center. You guys mentioned this, you knew if it's face, you're going to, you know, do the airway assessment. Frequently, they're going to need an IV. They're going to have a lot of fluid and electrolyte shifts. They may need to have a nasogastric tube, especially if there's any concern they've had any damage to their esophagus, etc. I think you guys talked about all of those things. You guys, I feel like you studied burns before. So when you're doing, wound care, you guys knew that like the skin is like your protective barrier. So they're really going to need protective isolation because they're at risk for infection. Everything that you do with them needs to be sterile. They're going to need pain medication before you start doing any wound debridement or wound care. They can have fluid shifts, so paying attention to their eyes and nose. You guys need to know they need increased calories and increased protein to recover from burns. Prevention of contracture, so like if they've had a burn around their wrists, that they're having mobilization exercises so they don't get their wrist in a fixed position. And they're going to need a lot of emotional support. So kids can also be sunburned. What sorts of things do you educate parents about for sunburns?
Make sure they wear sunscreen.
Mhm.
Even if
out.
you're black, wear
Yeah.
sunscreen.
There you go. I'm so glad
Yeah.
you said that. A lot of times black people, they don't think they need it, right? Or have you guys noticed that sometimes they're like, they don't need it. They do. They can still get skin cancer. Very good. And then what do you put on it? It's the same thing. Would you put something like a really thick, oily substance on a sunburn?
No,
No.
like aloe vera, Earl.
Aloe vera is good. Yeah. You want to hydrate the skin, but you don't want it to like trap the heat in with something that's really oily. And these sunscreens that have zinc oxide or titanium dioxide are more effective. So sometimes just having them read the labels of their sunblock. And then the opposite end is frostbite, which is just extreme, prolonged exposure to cold. If you were for some reason out cold for a long time, you would worry more about the head and the torso in terms of long-term survivability. So you would rewarm these areas before you would warm the extremities. In severe cases, they could end up with tissue necrosis and they can end up needing to have an amputation. So this would obviously be in the most severe cases. I'm gonna see where we are. So I'm gonna give you guys an option. Do you want to take a quick break or do you just want to power through and do a Kahoot? How about I give you 5 minutes? See what time it is. So if you can come back, at like just around 10 and we'll do the Kahoot and then we'll get started with the next section. Okay, sounds good, guys. Thanks.
Excuse me, Professor Brunel.
Welcome back, everyone. Your game pin should load here in just a second. Okay. Oh. When a parent asks about correcting the hypospadias of a newborn, what is the nurse's best response? No intervention is necessary as the defect will correct over time. Surgical repair is needed and usually performed before 18 months. Repairing the defect will increase the risk of testicular cancer, or corrective surgery is delayed until preschool. Myself on mute because I was coughing. So yeah, this is the one where surgery is usually done. There's a couple mild cases when they won't, but it's almost always done. And they ask that the parents don't circumcise the kids so they can use the foreskin as part of the surgical repair. So the mother of a 5-year-old taking prednisone for nephrotic syndrome asks about immunizations. What is the nurse's best response? The child needs antibiotics in addition to his shots. Vaccines interfere with the treatment of nephrosis. The immunization should be delayed, or the vaccine should be given, but in smaller divided doses. Yeah, so this is the one that, you're going to have to talk to the provider, but at least until they're off their prednisone, they should be delayed. So which physical assessment technique will the nurse omit when caring for a 2-year-old child diagnosed with Wilms tumor? Palpating the abdomen, assessing bowel sounds, range of motion exercises, or percussing ankle and knee reflexes? Good. So this is the palpating the abdomen. This is the tumor on the kidney. So you could damage the kidney, actually rupture the kidney tumor if you palpate. So a 6-year-old child with daytime enuresis complains of dysuria and urgency. The nurse recognizes that this could indicate what? Vesicular urethral reflux, nephrotic syndrome, acute glomerular nephritis, or a urinary tract infection. Good. So this is going to be your urinary tract infection. This acute glomerular nephritis, this is that can happen after a strep throat, and they could have like kidney failure, like not producing urine, etc. But these symptoms specifically, dysuria and urgency, you normally associate with a urinary tract infection. A 5-year-old boy is admitted to the hospital with acute glomerular nephritis. What is the probable cause? Recovery from German measles 2 months ago, a sore throat 2 weeks ago, a history of food allergies, or a recent UTI. So yeah, this is the one that's caused by strep throat. So a sore throat 2 weeks ago is probably what led to the acute glomerular nephritis. How is infant skin different than adult skin? It's thicker, has greater absorption, fewer sweat glands, or a smaller body surface area. Yeah, so it has greater absorption. So good. Several of you chose the smaller body surface area for their mass. They actually have a higher body surface area, not smaller. So you're more worried that they're going to absorb more medications through their skin. A child has sustained a 2nd-degree deep thermal burn to the hand. What is the best first action to take? Immerse the burned area in cold water, apply petroleum jelly, break any blisters, or apply ice. So good. You want to cool it down a little bit. You're not going to necessarily apply ice. That would be really cold. And you don't want to break the blisters because that would actually set them up for an infection. What would help the child with a serious burn meet nutritional needs during the subacute phase of recovery? Increase calories and protein, increase fat, decrease carbohydrates, or decrease calories. Very good. You're going to increase their calories and protein. They have a lot of energy needs to recover from the burn. So parents asked the nurse about the red area on the infant's neck that appeared a few weeks after birth. What is it likely to be? A port wine nevus, Iturtrigo, a strawberry nevus, or impetigo? Okay, so this port wine and the strawberry, they're both kind of that reddish discoloration, but the port nevus is present at birth and the strawberry nevus appears a few weeks after birth. So a child is brought to the emergency department with burns on the face and chest. What is the nurse's first priority? Assess respiratory status, insert a Foley catheter, remove clothing, or administer pain medications. Very good. Assess respiratory status. Nice job, you guys. Okay. What should the nurse stress to the mother of a child with impetigo? Small cuts and bites should be treated promptly. The crest on the lesion should be left in place. The lesions may spread, but the disease is not contagious, or the condition is caused by herpes simplex type 1. Yeah, so you guys are a little bit torn between the red and the yellow. So it is the small cut should be treated promptly because you don't want to get a secondary infection. They do actually recommend that you kind of gently rub off that crusty region. That crusty stuff is contagious. So you want to kind of wipe it off and then put the cotton ball or whatever that you use to clean it away so that other kids can't touch it. All right. All right, good job, Chanel. Good job, everyone. So thank you for participating. So we have two more chapters. I'm gonna be totally honest with you. We're gonna focus most on the metabolic one because I know that's gonna be more heavily tested. So I'm gonna pull up the communicable disease one first, and I'm gonna point out some key points that I know that you need to know, and then we'll move on to the metabolic chapter that is going to be more heavily tested, and also a lot of the communicable disease stuff I think you've had in other classes. Okay, so communicable diseases. It's going to take a second to get big. So, you know, communicable diseases are diseases that spread from one person to the other. We've made a lot of progress in stopping communicable diseases through immunizations, but there are a couple that are really kind of worldwide things that we still have to pay a lot of attention to. HIV, hepatitis, tuberculosis, and sexually transmitted infections are worldwide problems. So there's some certain things to sort of just make sure that you know the term. So communicable disease can be transmitted from one person to another. The incubation period is the time between exposure and the onset of clinical symptoms. So you're around someone that has a runny nose and then you don't get a runny nose for 4 days. That 4 days is the incubation period. And the prodromal period, the time between the earliest symptom and then other symptoms like a fever or a rash. So maybe you start having a runny nose, but then you get a fever 4 days later. That period between the runny nose and the fever is the prodromal period. And vector is the animal, you know, it's not always an animal, but whatever is carrying the disease that passes it. So like malaria is sped by mosquitoes. Ebola is sped by animals. So if there's a specific, you know, if it's not just in your snot or your vomit or whatever, if there's a specific animal or insect that carries it, that is called the vector. And I think you guys are probably familiar with most of these terms. So pandemic is a worldwide infection, and an epidemic is a sudden increase in disease in a specific area. And endemic is when a disease just exists in the community. So we were in a pandemic, and in a lot of ways now COVID is an endemic virus. It's just out there. It's in our communities. An opportunistic infection, this would be something that you would see in someone that was immune compromised, and then a bacteria or a virus that doesn't make us sick will make them sick. So someone that has HIV can get like a really bad pneumonia from common bacteria, whereas the rest of us that have normal immune systems wouldn't catch or wouldn't develop that pneumonia. And then a healthcare associated infection, this would be like you have a urinary catheter in someone and they get a urinary tract infection, or they have ventilator associated pneumonia. So something that they acquire when they're in the healthcare system. So virulence refers to how sick a pathogen makes you. So it's going to be dependent on a lot of things, how old you are, your gender, your genetic makeup, your nutritional status. All of these things kind of influence how sick you're going to be once you're exposed to a specific pathogen. So this slide here, I want you to pay attention to. This is the different types of immunity. So an acquired immunity is going to be like you had flu or you had the flu shot. So your body develops antibodies either because you had the illness or you got the shot. So both of those are acquired immunity. And I think you will be asked in the future, you know, what type of immunity do you get from immunizations? And it's going to be acquired. And then passive immunity is that you give the antibody and then they have protection for some amount of time, but it doesn't last as long as acquired immunity. So who can give me an example of passive immunity?
Breastfeeding.
Breastfeeding. Very good. So the mom passes antibodies to the baby through the breast milk. Sometimes you can give something called IVIG, which is, you know, antibodies that you get from other people's bloods, and you give them antibodies. And that's the same thing as passive immunity. You're not giving them immunity to a specific illness. You're just giving them antibodies that they can then use to fight infections, and it doesn't last as long as acquired immunity.
What about a bone marrow transplant? Would that be considered? Like, whenever you have a transplant given, are you passing things along that way?
When you have a transplant, so when you have a bone marrow transplant, first you're going to really kind of tamper down their immune system so they are able to accept the transplant, so their body doesn't produce antibodies against the transplant. So in terms of like when their immune system comes back, if they start producing their own antibodies, so that's just going to depend, like, because if once their bone marrow comes back, then, you know, and they produce their own antibodies, then they're going to have acquired because they're producing their own. So I guess the thing with acquired is you receive either the you know, a vaccine, or you have the illness and then your body produces antibodies. You yourself produce those, whereas in passive immunity, you're giving the antibodies. So in a bone marrow transplant, you're not giving anybody any antibodies. So over time, their immune system should come back and they'll start producing their own antibodies.
Okay.
So you can have direct or indirect infection. So direct, like I'm with you, you cough on me, and then I get infected. Or indirect is like you sneeze or cough on a teddy bear, and that teddy bear goes to another child's room, and then that child gets the infection. So direct is person to person, and indirect is through an object. I'm going to go ahead here a little bit. There are certain things that I think you know, but I would just kind of remember, you know, how do you stop the spread of infection? Always thinking about the type of precautions that you need to be using in the hospital. So standard precautions for everyone. And then when would you use droplet precautions? What sorts of patients would require droplet precautions in the hospital?
That's tuberculosis.
Tuberculosis is going to be the negative airflow, the airborne precautions. Droplet is going to be something as simple as like RSV. So droplet, you always have to wear the mask, and then airborne here is going to be where you have to wear that N95 mask. You have to like fitted to make sure the mask fits. So they have the reverse airflow in the room, and that would be for something like TB. And then how about contact precautions? What sorts of patients would you use contact precautions for?
C. diff, MRSA.
Yeah, very good. So when you're worried about something on your hands, but it's like droplet is going to be like something comes out of your nose or mouth from your respiratory system, they're going to be on droplet. But something like wounds or diarrhea or something where it's really you're worried about touching body fluid, so you need to make sure you always have the gowns and gloves on. So there is a point here that someone mentioned C. diff. You really need to be, you know, making sure that you're wearing the gowns and gloves, and then you don't want to be like cohorting people where you could spread the infection between both of them. Hand hygiene is required, and you need to be thinking about the alcohol-based solutions for certain things like C. diff. It's really better to wash your hands and not always use the alcohol-based solution because it doesn't really kill the bacteria that's on your hands. You guys already talked about droplet. Here's the hand hygiene. So you want to make sure you use the hospital approved soaps, and then the hand sanitizers, you know, at the very least, but you should be washing your hands also, and then not doing the long nails because you get a lot of stuff underneath the nails. And if the caregiver has any sort of lesion, they should be helping out until it's all cleared up. And this is this point about the alcohol-based hand sanitizers not being used if the patient has C. diff, because it doesn't kill the C. diff. So, and then it's very, very contagious. And if you have it on your hands at all, you can spread it from one patient to the other. I think that is the highlights of this chapter. You know, when you're doing patient education or parent education, talking about like good hand hygiene, you know, good hygiene in general, cleaning the house, making sure people aren't sharing towels, control of insects, not having sandboxes in the yard. Obviously, cats like sandboxes. You don't want your kids to be exposed to cat poop. So thinking about all the different ways that you can educate parents, because, you know, food storage, milk being left out, all of these things can help spread infections within a family. So this is another one. There was a slide in the skin section that showed you the picture, like the difference between a macule and a papule. So this is just a good slide because it goes over and gives you the specific terms in a very easy to understand way that kind of helps you differentiate between the different types of lesions that you can see with a rash. So immunization is one of the main ways that we have to stop the spread of communicable diseases. So, you know, as a nurse, you know, be knowledgeable about immunizations, be able to educate people about immunizations. So for immunizations, who knows, like, what are the 2 childhood immunizations that you don't give to babies? You wait till they're a little bit older. They get like the PCV7 and the DTaP and the HIB and the IPV. They get all those. But what are the 2 that you wait until they're a little bit older, at least over the age of 2?
Is MMR
MMR.
one of them?
Yeah, very good. And there's one more.
Is
Is
it the
it Bella?
hepatitis?
Yeah, so hepatitis they get when they're young. It's the varicella. So those are the 2 that you wait until they're getting closer to like preschool. And they're both they contain attenuated viruses. You need to make sure that they're a little bit older. So those are the 2 that you're not going to be given to infants. So all the other ones, they're getting like 2 months, 4 months, 6 months. They're getting them frequently throughout their infancy, but the MMR and the varicella, you wait till they're a little bit older. So good job, you guys. I know that is not going all of the PowerPoints. You guys have all of them, but those like knowing the basic immunization schedule through infancy and knowing they don't get MMR and varicella, and then knowing the different types of immunity, like the passive versus acquired. Those are the 2 main things that I know you need to know from this chapter. So we're going to go ahead and move on to the metabolic conditions. Let's see here. So we're talking about hormones and enzymes when we talk about the endocrine system. So hormones kind of control all sorts of different things in your body, your growth and your development, your sexual maturation. So there's hormones do a lot of different things in your body. And this picture just kind of shows you all the different places that hormones are produced. So hormones are proteins that are submitted from glands. And then they have a target organ that where they work. So you need a normal balance of hormones to do most of your body processes. So they're submitted by glands and they go into the bloodstream, and you having too much or too little causes a disease. So that's the hormone side of things. And then inborn errors of metabolism, which are more related to enzymes. So you don't have an enzyme. So enzymes break things down. So hormones help processes move along, like thyroid medication or thyroid hormone. You need that energy level, etc. Whereas enzymes, you need specific enzymes to break things down. So if you don't have an enzyme, for example, to break down your food, then you're not going to get the nutrients from your food. So inborn errors of metabolism are enzyme related. You're not producing a specific enzyme. And then endocrine related problems are you have either too much or too little of a hormone. So, you know, you need to pay attention to the endocrine system just because it can have permanent consequences. So for example, hypothyroidism, you can have what's called congenital hypothyroidism. If that goes undiagnosed, it can lead to permanent mental retardation and brain damage. So you know, if you have something that seems a little bit off with a baby, you need to be kind of thinking it's not always an infection. It could be a hormone problem or an inborn error of metabolism that's causing them not to develop normally. So there's a lot of different tissue diagnostics and different ways that you can help figure out exactly what's going on. I guess the main thing for you to really think about is that sometimes these problems are a little bit harder to diagnose. So there can be like a more thorough evaluation about what could be going on. So in terms of inborn error of metabolism, these are an enzyme, remember? So like Tay-Sachs disease, you don't have the enzyme to break down lipid. So then those lipid or fat deposits build up on nerve cells, and over time they cause mental retardation. So you see this primarily in the Ashkenazi Jewish population, and it is a genetically inherited trait. So if somebody says that they have a nephew that had Tay-Sachs, then the family should be tested to see if they're a carrier. So Tay-Sachs is, there's no treatment. So the nursing care is going to be palliative, and you should offer genetic screening because it does run in families. And it's very sad because there's no treatment. So they usually die by the time they're about 5 years old. So they're born normal, and then they have like this progressive mental retardation. So in terms of endocrine, there's two main ones. The two most common are going to be diabetes and then hypothyroidism. So hypothyroidism, you're not producing enough of the thyroid hormones from the thyroid gland. And sometimes you won't see symptoms for several months. So hypothyroidism in young children is going to be, you know, have some similarities to hypothyroidism in adults. So what do you think? What sorts of symptoms will a baby with hypothyroidism have?
Fatigue, tiredness.
Very good. So they don't have enough energy. Their metabolism is slowed down. Sometimes they have a big tongue. So sometimes they snore or they have noisy breathing. They can have cold skin, right? Sometimes their hair is dry and brittle. And this is the one that it's important to treat because it's treatable. Like Tay-Sachs, there's no treatment. So those kids are going to just get progressively more retarded over time and eventually die. Whereas hypothyroidism, there's a specific treatment, you can treat it and they can have a normal life. But if you don't treat it, then they can have irreversible mental retardation. So it's really important to pay attention to their symptoms and then give them the appropriate treatment. And what do you think the opposite is? What would hyperthyroidism look like? If hypo is sleepy, dry skin, kind of lethargic, what would hyper be? Jittery.
Very
What else?
jittery. Yeah.
Jittery. Would their heart rate be
Anxious.
high or low?
High.
High. Okay. Kind of a higher temperature. Think about being more revved up. So hypothyroidism can be congenital, meaning they're born with it, or they can develop it over time. So that would be more of like a juvenile. And like I said previously, it's really important to diagnose this and treat it because it can cause permanent brain problems. So it is mandatory at all 50 states, but just remember, not every test is 100% accurate. Sometimes babies are born at home, they're born in foreign countries. So you should just remember how serious it can be if they're not diagnosed and treated early. So you're going to give the thyroid medication. Their hormone levels are monitored regularly. And to make sure the parents know that it's a lifelong. It's not like they're going to outgrow their hypothyroidism.
So
yeah, go ahead.
the medication for that, does it come in liquid form?
They have an oral suspension. Yep.
Okay. All right.
And then you guys mentioned this. So, you know, you can have hyperthyroidism or you could take too much of your thyroid medication, which would give you a lot of the same symptoms. So signs of too much thyroid replacement would be the high heart rate, the irritability, the sweating, the weight loss, the dyspnea. All of these would be things that you would associate with either hyperthyroidism or taking too much of your thyroid medication. So always think about how you should respond to the medication. And then if they're having these symptoms of this would be too much, fatigue, sleepiness, constipation, that would be maybe they're not getting enough. So diabetes insipidus, sometimes this is confusing because it has the word diabetes in it. So it's not diabetes mellitus. Has anyone heard of diabetes insipidus?
Yes, it's peeing a lot, I think.
Peeing a lot. Very good. So this is the one where you think about a lot of urine output. So, and it's uncontrolled diuresis and it can cause dehydration. So, because they pee a ton. So this slide here, it goes over different hormones that are produced by the pituitary gland. So the posterior pituitary, this is where the posterior pituitary is where you're going to see the diabetes insipidus. So it's one hormone for decreased or increased. So decreased hypopituitarism causes decreased antidiuretic hormone, which then leads to diabetes insipidus. And increased hypopituitarism leads to increased antidiuretic hormone, which then leads to SIADH. So just to think about, so antidiuretic hormone, so antidiuretic, it stops you from peeing. So if you have too much antidiuretic hormone, you don't pee enough. And if you don't have enough antidiuretic hormone, then you pee too much. So you have two different endocrine disorders that are related to the same hormone. And whether you have too much or too little depends on, you know, what alteration you have in your urine output. So it's kind of similar like the thyroid hormone. If you have too much of the thyroid hormone, you have hyperthyroidism. If you have too little, you have hypothyroidism. So if you have too much ADH, you have syndrome of inappropriate antidiuretic hormone. And if you don't have enough ADH, then you have DI. So sometimes it can be like congenital, it can be associated with certain problems that you're born with, or it can be a closed head injury, like your pituitary brain's, when you have increased intracranial pressure, that can put pressure on your pituitary. So then it's not unusual, like a symptom of a closed head injury is DI, when they start having that really, really brisk urine output because they have increase in their ICP. So this next one here, I'm just going to point out to you, this kind of goes over the same thing where it talks about like what happens when you have increase or decrease of a specific hormone. These are not as tested as the SIDH and the DI. So I would pay attention to both of these slides in terms of understanding, for each hormonal imbalance, you can have too much of a hormone or too little, and that's going to result in two different disease processes. But if you really to pay attention and be able to pinpoint, I would focus on the SIDH and the DI. So diabetes mellitus is the most common endocrine disorder. So who can kind of summarize what diabetes mellitus is? What's the main problem when you have diabetes mellitus?
Insulin production.
Insulin production. So what happens if you don't have insulin?
The risk for hyperglycemia.
Yeah, so you need insulin to move glucose into your cells. So you're at risk for hyperglycemia. Very good. So what happens in your body? So if you don't have enough insulin and you're not able to move glucose into your cells, what does your body do for energy? Does anyone know?
Break down the fat.
You guys are so good. So you break down your fat and protein, which then leads to the accumulation of ketones.
Ketoacidosis.
You get ketosis and you can get what's called diabetic ketoacidosis. Very good. So incomplete metabolism produces ketones known as ketone. If you have increase in ketonemia, you'll also have, sometimes they you have diabetics test their urine for ketones. So if you're spilling ketones in your urine, that's a sign that you're in ketosis. So, you know, when you're dealing with a pediatric patient that has diabetes, you're always going to be trying to optimize their growth and development and make sure that they are growing and developing as normally as possible. So there's some long-term complications of diabetes. So blindness, kidney disease, neuropathy, they can have circulatory problems. So just making sure parents know this is a long-term disease. They're never going to outgrow their diabetes. They're going to be on diabetes medications for the rest of their life. And there's a lot of serious complications if they don't control it. So this is, you know, a breakdown of the different types. So type 1 is going to be insulin dependent. They don't produce enough insulin. What is type 2 diabetes?
It's about the diet, not controlling your diet.
Yeah, so it's more like overweight, obesity, sedentary lifestyle. It's something called insulin resistance. So their cells, even if they have insulin, the insulin isn't really effectively helping the glucose get into the cells. So with kids, though, you usually start with diet and exercise modification before you would start any sort of medication. So a type 1 is 100% going to need insulin. Type 2, they do like diet and exercise modification, and then they might start an oral medication. And last worst case scenario is they might need insulin, but that would be after been trying multiple other things. Gestational diabetes is going to be when you're pregnant. And this, you do need to know this. So there's a bunch of different chromosome abnormalities that are associated with diabetes. So 6, 7, 12, and 20. You need to remember that those 4 chromosomes or defects on those 4 chromosomes can cause diabetes. So there's certain sort of diagnostic criteria that we use when we're talking about diabetes. So a fasting blood glucose of greater than 126 on 2 separate occasions. So fasting being no food intake or anything other than water for 8 hours. And then you guys talked about, so type 1, you're not producing insulin, and type 2, triggered by sedentary lifestyle and obesity. So this is going to be the most common metabolic disorder. Children, it can be harder to manage. Their growth is not linear. Sometimes they speed up and slow down. They like to eat junk food. They don't want to be different than their peers. So there's lots of things about make diabetes in childhood more difficult. Sometimes they're diagnosed early. Sometimes they develop ketoacidosis as their presenting sign. So what are the common symptoms of diabetes? You have it here, but you can tell me. The
Thirst.
3 P. Thirst,
Excessive
polydipsia.
thirst.
Frequent urination.
So,
Excessive
and then,
urination.
yep,
Thirst.
and then one more. Urination, thirst, and then what's the third one? What does that
Hunger.
polyphagia mean?
Hunger.
Hunger. So there's the 3 Ps with diabetes mellitus: polydipsia, polyuria, polyphagia, and there's 2 Ps with diabetes insipidus. What do you think the 2 Ps are for diabetes insipidus?
Peeing a
Polyuria.
lot.
Polyuria, and then if you're losing fluid, what are you going to want to do?
Drink.
Thirsty.
Thirst, right?
So polyuria and polydipsia go with DI, and polyuria, polydipsia, and polyphagia go with DM. Very good. So sometimes kids will have these symptoms and then they'll do a blood sugar and in fact, it's elevated. So hyperglycemia is what results if you don't have enough insulin. And we talked about that you use fat and protein for energy production if you're not able to move the glucose into your cells. So it's normal for kids to be in a state of denial. They don't want to believe that they have diabetes. These are kids that are going to be part of a multidisciplinary team. They're usually going to have an endocrinologist that helps manage their insulin. Talked about 126 as their fasting level. You guys have probably heard of the hemoglobin A1C. This gives you a snapshot of how high their blood sugar has been over time. So diabetic ketoacidosis, this is going to be like the severe form if you don't have insulin for a period of time, and then over time you break down your fat protein and you have a buildup of ketones. So it's the end result of not having enough insulin. So things that you're going to see are ketones in the urine. You're going to have a low pH, right? It's an acidosis. It's a hypertonic dehydration. They have like a fruity odor to their breath, nausea, altered level of consciousness. So these are kids that are normally going to be admitted into the intensive care unit. These are your basic treatment goals. Making sure they develop as normally as possible, that they start learning about managing their disease. What age do you think you're going to start teaching kids to inject their own insulin? What do you think? Can a 7-8-year-old start learning, or is that too young?
7.
Yeah. So you can start teaching them, right? And what are some things to think about? Like, how do you position the needle? Where do you want to inject the insulin?
How you clean the site, just to keep it clean and keep down infection.
Okay, you want to make sure you're cleaning the area first. Does it go in the subcutaneous tissue or into the muscle?
Sub-Q.
Sub-Q, you don't want to put it in the muscle. Very good. There's a slide about this here.
Would you teach them not like to rotate sites too?
And you teach them to rotate sites. Very good. And this, so this someone said age 7, you were 100% right. This is where you can start teaching them to perform their insulin injections. This one here has the different places on your body where you're likely to have an accumulation of subcutaneous tissue. So this is where you can give the shots. You guys should be able to recognize the difference between like a long-acting and a short-acting insulin. So can you tell me some names of some short-acting insulins? Which one is shorter acting, regular or NPH?
Regular.
Regular, okay.
Like Humulin and all that.
Humulin, Humalog are fast acting. Glargine, NPH are longer acting. So there's 2 that you can mix together. You can mix regular and NPH. Have you guys gone over this before? What's the basic
Clear
steps?
and cloudy.
Clear to cloudy. I also remember R to N. Okay. And do you put the air in first?
Yes.
Yes.
Yeah.
Yeah.
First. Okay. So most of the time they do injections. They can have an insulin pump that kind of responds automatically to the blood sugar. It has a monitor in there and it releases insulin. So they can have what's called insulin shock, which is just going to be hypoglycemia. They got too much insulin or they didn't eat enough based on the amount of insulin that they gave. And also can be related to poorly planned exercise. So when you exercise a lot, that can drop your blood sugar. So you need to be careful with kids that are diabetic if they're playing like competitive sports, that, you know, they eat before they play, or they're not taking, maybe really coach them on making sure they're having a consistent diet so they're not dropping. Regular exercise is a lot better than like brief spurts of really intense exercise, because your body can kind of adjust to a regular exercise schedule. Whereas if you don't exercise for 2 weeks and then you go climb a mountain, that can be really hard on your body and it can block your blood sugar. So just encouraging, they can still play sports. They need to eat before they play. You never want them eating on an empty stomach. They should have money around if they have to buy food. They should have sugar with them if they go to sports practice. So if they feel a little bit jittery, they have some sugar to suck on. So what do you do if you're worried that someone is hypoglycemic? So the main symptoms are irritable, kind of pale, sweaty. What's your nursing intervention?
Let them have something sweet around. Like
Yeah.
carrot around and that.
Suck on a hard piece of candy, a couple ounces of juice. You need to have something available to give them some sugar. So right on, orange juice, hard candy. They usually start to feel better in a couple of minutes. You can have glucagon, which is injectable glucose, available if they are not able to swallow, or if you don't have the thing that they can suck on. So there's a couple of different what we call phenomenons related to diabetes. So this is actually like a rebound hyperglycemia. So your body has natural ways of regulating your blood sugar level. So hypothetically speaking, let's say you take your insulin before you go to bed at night and your insulin dose is actually too high. So then you develop a hypoglycemia in the middle of the night and your body kind of responds by releasing cortisol and epinephrine. You release glucagon from your liver, and that brings your blood sugar up. So then when you take your blood sugar in the morning, your fasting morning blood sugar, it's high. So if you see that morning blood sugar and it's high, like the immediate reaction is, oh, they didn't take enough insulin when they went to bed. But it could be the opposite, that they took too much insulin. They had a hypoglycemia in the middle of the night, and then they had a rebound hyperglycemia. So the only thing to really remember is that, you know, a morning hyperglycemia doesn't necessarily mean not enough insulin. It could be a reaction to having a low blood sugar in the middle of the night. So just thinking through that and not automatically giving somebody more insulin just because they're waking up with that high blood sugar in the morning. And that's the opposite of the dawn phenomena, which is where they have the early morning hyperglycemia, but it's not preceded by hypoglycemia in the middle of the night. So, you know, you're going to deal more with type 1 diabetes in kids, but type 2 is possible. This is going to be your sedentary lifestyle, obesity. You're going to do diet management first, and then usually you start with oral hypoglycemic agents if you need them, and then maybe insulin if you can't control it with diet, exercise, and the oral agents. Do you guys have any questions about any of that information? Okay, I'm going to go ahead and pull up a Kahoot that I know that will help you with your quiz today. So I'm going to go ahead and do the Kahoot with you guys, and then you guys can take another 5-minute break. And when you come back, your quiz 5 will be up. So what occurs as a result of inadequate secretion of insulin? Protein synthesis is increased. Increased fat breakdown leads to ketonemia. Rapid conversion of carbohydrates to glucose occurs, or serum glucose levels are markedly decreased. Right. So this is going to be, if you don't have enough insulin, you can't move glucose into your cells, you break down fats and protein that leads to ketonuria. So protein synthesis, it doesn't increase, it breaks down protein. Glucose levels will be lower. I'm higher, not lower, I'm sorry. And then you don't have rapid conversion to carbohydrates to glucose. So this is the main thing. You break down your fats and protein, which leads to a buildup of ketones. So a child receives a combination of regular and MPH insulin at 8 a.m. At 8:45 a.m., breakfast has not been delivered. So what is the nurse going to do? Is she going to give the patient a snack of graham crackers and milk, give the patient more insulin, ambulate the patient for a short period of time, or tell the charge nurse? Okay, So good. A couple of you chose the charge nurse. It's not a bad thing, but you need to make sure that you're giving some carbohydrates to this kid because that regular insulin is going to be peaking and you're going to drop their blood sugar if it's been 45 minutes. So a mother reports that her 4-month-old infant is lethargic, sleeps 18 hours a day, and snores. What does the nurse suspect? Hypothyroidism, type 1 diabetes, Tay-Sachs disease, or hyperthyroidism? So this is the hypothyroidism, the sleepy, lethargic, they can have a bigger tongue, so they tend to be noisy breathers. A couple of you chose Tay-Sachs. Tay-Sachs is where they can't break down lipids, so they have lipid deposits on their nerve cells, brain cells, that causes mental retardation. So after a closed head injury, the child begins to excrete copious amounts of pale urine and has a drop in blood pressure. What does the nurse suspect? Hypothyroidism, diabetes mellitus, hyperthyroidism, or diabetes insipidus? Good. So this is going to be your DI, your diabetes insipidus. That's the posterior pituitary. You sometimes can put pressure on that gland when you have an increase in your intracranial pressure. Which chromosomes are associated with type 1 diabetes? 6 and 7, 12 and 20, or all of the
Oh,
above?
shit.
All right, so it's all of them, 6 and 7, 12 and 20, all 4 of those. So which processes does the nurse explain the endocrine system is primarily responsible for controlling? Stress, growth and maturation, reproduction, or all of the above? So it is all of the above. So stress is going to be like your cortisol production, growth and maturation, reproduction. I would just point out, it doesn't necessarily control your sexual identity. This is going to have also to do with like some personality characteristics. So these 3, yes, but not necessarily your sexual identity. So which symptom does the nurse recognize in an indication of synthroid overdose? Tachycardia, diaphoresis, irritability, or all of the above? All right, so it's all of the above. So Synthroid, this is the name of the synthetic thyroid medication. So this is what they take if they have hypothyroidism. So an overdose would give you the same symptoms of hyperthyroidism. So which comment made by a school-age child indicates that he needs more teaching about diabetes mellitus and exercise? Sometimes I skip my breakfast when I have a game in the morning. I make sure I have emergency money when I have soccer practice. I play soccer games that are scheduled after dinner, or I carry a piece of hard candy with me in case I feel shaky. Yeah, so you want to make sure that they eat before they play. So the best answer is this makes you think the kid needs more education, that he skips his breakfast. You don't want them playing soccer on an empty stomach. Very good, you guys. Nice job. So go ahead and take a 5-minute break. So come back at 11. And when you come back at 11, your quiz 5 will be up, okay?